So this was a randomized phase 3 study of pembrolizumab in combination with trastuzumab and chemotherapy. And this is a placebo-controlled trial in first-line HER2-positive G-junction and gastric adenocarcinoma. By way of background, so this trial was designed based on both preclinical data demonstrating synergy for dual PD-1, anti-PD-1 and anti-HER2 blockade in transgenic models of HER2-positive disease, showing dramatic tumor regression with combination therapy. We then conducted a phase 2 study at Memorial Sloan Kettering examining combination of pembrolizumab with trastuzumab and chemotherapy in phase 2 setting, and noted dramatic overall response rate, near doubling of overall response rate when you looked at combination dual anti-PD-1 and anti-HER2 blockade. Historically, the overall response rate in first-line setting based on the TOGA study with trastuzumab and chemotherapy is approximately 47%. We saw 91% overall response rate. So subsequently, there was another phase 2 study recently presented coming out of Korea, also demonstrating promising clinical activity. So when we came to phase 3, what's satisfying to see is that for the first time, we saw dramatic responses in the phase 3 setting once again. And this was during the first interim analysis, which was a pre-planned analysis based on the initial protocol design. And this was the rationale, is to study dual combination in first-line setting, and the data is quite promising. This was a phase 3 study. Placebo-controlled patients were randomized to receive either standard of care of chemotherapy plus trastuzumab. Tumors were confirmed to be HER2 positive by IHC, so IHC 3 plus or IHC 2 plus and FISH positive. This was a central confirmation. This was a large global study enrolling patients all over the world. And patients were randomized in a placebo-controlled fashion to receive either chemotherapy with trastuzumab and pembrolizumab or chemotherapy with trastuzumab and placebo. The primary endpoints were dual PFS and OS, with a secondary endpoint overall response rate. The first interim analysis was to look at the improvement in overall response rate, and this was a pre-planned interim analysis based on the protocol specified criteria. What we found at the interim analysis is that overall response rate for combination of trastuzumab, pembrolizumab, and chemotherapy was dramatically improved. It was 74% overall response rate compared to 51% overall response rate. Furthermore, the treatment was well tolerated. There were no new signals for side effect profile and adverse event profile. There were more immune-related adverse events associated with pembrolizumab therapy as expected, but otherwise, this was a very well tolerated regimen, relatively easy to administer, and certainly the response rate was dramatically improved. Based on this interim analysis, the FDA approved this combination for use in the United States for patients with HER2 positive disease in first-line setting. These results are an important step forward in our understanding of biology of this disease. We were able to show that you can augment HER2 inhibition with trastuzumab with use of anti-PD-1 therapy. So it's transformative for patients with HER2 positive disease, where we're already using this combination in standard practice, and it is practice changing. It raises the bar for HER2 positive disease. So going forward, other studies, the future of this field will be transformed, where the combination regimens will be compared to this standard regimen. And more importantly, for the field as a whole, it highlighted a new approach to treating this disease, where combination strategies, and we've known that combination strategies is the way to go because this disease is so aggressive and difficult to treat. But for the first time, we demonstrated a synergy between the two agents. And perhaps we can apply the same concepts to other targeted agents and other biomarker selected patients where HER2 is an important validated target, Other targets fell short, such as EGFR and MET, and perhaps we need to revisit those approaches and those strategies using combination therapies with anti-EGFR and anti-PD-1 therapies and other similar design studies. I think it's important to highlight how quickly this field is evolving. Anti-PD-1 therapy has transformed the field both for HER2 negative and HER2 positive disease. For HER2 positive disease, we have this exciting new option. It highlights how critical it is to know the HER2 status of your patients and to offer them these options. Certainly, PD-1 therapy is important in first-line setting, but knowing the HER2 status of your patient's tumor is critical. It suggests that biomarker testing in routine fashion in all patients it will be important to further advance care for our patients. And we need to remember to personalize treatment for each patient, even with rare disease subsets, such as HER2 positive, MSI high tumors, EBV positive tumors, and so on.